Vivek,
Yeah.
want us to answer this question now or later?
No. Later, not now.
Yeah.
Not now.
Okay.
Not now. As I'll flash then, not now. Certainly not now.
Okay.
We line now, right?
Yeah, we are live now. Please go.
Amazing. I'm very impressed.
Thank you.
Thank you. Yeah.
Very
Good,
impressed. Yes.
good afternoon. Thanks, App, for
Yes.
coming here. Good afternoon, everyone. Welcome to Shoulder Elbow Society India online webinar series. This is the 9th webinar we are doing on this exciting topic of today, which is frozen shoulder. Without much ado, I'd like to share my screen. Oh. Shoulder Elbow Society of India. So we had two consensus meeting on rotator cuff repair. It was very well received. I mean, inspired by that, around 10 members who was doing arthroscopic work have joined Shoulder Elbow Society of India. A warm welcome to those 10 new members of SESI to this meeting too. So why we talk about frozen shoulder is one of the very common presentation in the general orthopedic practice as well as the shoulder surgeon's practice. And the original frozen shoulder name was coined by Codman in 1934 to denote restriction of both active and passive movement of the shoulder with a normal X-ray. And he described this classical three phases: freezing phase, frozen phase, and thawing phase. All together can last from up to 24 months for recovery. And he recommended a supervised neglect as the mainstay of treatment with focus on non-operative measures, analgesics, physiotherapy, and occasional steroid injection, and a strong reassurance that it is self-limiting. Well, a classical frozen shoulder tend to be self-limiting in over 90% as per his series, and around 5 to 10% may remain with a little bit of residual stiffness, and they might usually live along with the residual sequelae, like what we are living with corona now. So the nomenclature, but the frozen shoulder is the classical difference, but there is a wide spectrum of nomenclature: stiff shoulder, adhesive capsulitis, primary, secondary, tertiary, intrinsic, extrinsic, PTSS, POSS. Why? There is no consensus about a definition or classification of a stiff shoulder. So the ideal classification should be reproducible and communicable. If you say something, that should mean exactly the same thing to your team members so that the patient gets the best treatment. Second, able to identify the pathology, thereby guessing the prognosis, explaining to the patient and attendant. It should help to decide the treatment and also should allow you to compare your outcome with the corresponding similar status published in the literature. So the ISACOS, the Upper Extremity Committee, gathered in 2015 and had extensive meeting on this contentious issue, and they come up with the beautiful written book on shoulder stiffness, around 235 pages. I recommend this a good read for anybody interested in shoulder stiffness. So as per their classification, stiff shoulder means patient presenting with restricted range of movement, whatever be the cause. The classical frozen shoulder recommended to be used for the primary variety, idiopathic. Secondary stiff shoulder, anything with a known etiology, and they do not recommend the use of adhesive capsulitis. And just to remind your attention to this concept of shoulder machine, where the switch or the electric cord is a neurological. And second is the motor cable is the musculotendon unit. The bearing is a joint, housing is a capsule, lever is an extra articular structure. This forms the basis, thanks to Greg Bain, the basis for pathoanatomical classification, where the problem is intra-articular, capsular, extra-articular, or neurological. You should address that. Second, we should also remember the original insult or trauma or injury can lead to sequelae, and that if unhealed can lead to capsular contracture. Then the progression of the disease or the trauma itself can lead to secondary insult. With the anatomy, with the pathology, with the timing of presentation, that it can become complicated. So it's our duty to work up whether this is primary or secondary. Second, what is the anatomical structure involved? Is the natural history and prognosis, is it known? Are we going to accept it or modify it? You should respect the pathology, it is the background for the stiffness. And you should address the anatomical issues that has been altered. The treatment widely varies: oral medication, NSAID, steroid injection, exercise rehab program, joint distension, manipulation and anesthesia, arthroscopic capsular release. There are wide options, treatment options. Is it evidence-based or eminence-based or experience-based? Lot of questions, no clear-cut answers. So in order to gain a perspective of Indian shoulder surgeons practice, thanks to our secretary, Dr. Vivek Pandey, who has formed this survey of over 25 questions. The survey was sent to all the SESI members, and I'm sure I have not seen the results yet because I'm just kept as a panelist for today's purpose. It's exciting to say over 150 members have answered this survey from all around India. Thanks to so today we are here with the consensus meeting on frozen shoulder with eminent faculty as panelists: Professor Aap Willems from Netherlands, Dr. Amit Modi from Leicester, UK, Dr. Kush Narong from Sussex, UK, myself, Dr. Ashish Papulkar from Pune, Dr. Dinsha Padiwala from Mumbai, from Dr. Pradeep Kumar Gupta from New Delhi, Dr. Swanendu Samanta from Kolkata, Dr. Josh Schiller, Calicut, and Dr. Sundar Rajan from Coimbatore, Dr. Raghuveer Reddy from Hyderabad, Dr. Nilesh Kamath from Pune. We have eminent faculties today with our backed up by our SESI survey. I pass the stage to Dr. Vivek Pandey to start this online consensus meeting on frozen shoulder. Thanks, Vivek. Vivek?
Yeah, I'm here. Yes. Thank you, Ram. I think you made my job quite easy because you have already given the glimpse and you have highlighted the areas where we still do not have a clarity, where we are still lacking in the consensus. We have been traveling length and breadth of the country. We have been meeting people, and this is one topic. I mean, although in shoulder, almost every topic remains quite controversial. There are a variety of opinion in the country itself, forget the worldwide. But this is one condition which is also dealt by a lot of general orthopedic surgeons who continue to get, they're debated that what is the most appropriate treatment of this condition at the various stages. So we thought of, bringing all those potential contentious questions and issues on one platform where we'll have the people from the eminent people from the country and as well as worldwide who can share their thoughts, and we can come to some consensus and conclusion, because this webinar is going to be watched by a lot of physiotherapists also, apart from the general orthopedic surgeons and the sports surgeon. So let me start the webinar with the with what we did actually to have this webinar, which we decided about 4 weeks in advance, 3 to 4 weeks in advance. About 3 days back, we floated a 25 questions survey on the Telegram group of SESI members, Shoulder Think Tank and Arthroscopy Academy group on May 24. And this was intended only for shoulder surgeons. A total of 142 surgeons responded to 25 questions related to frozen shoulder, and survey was closed yesterday by afternoon. Some standard questions were not asked, as largely the literature agrees to the fact, and I declared it before we started the webinar, that will be physiotherapy. So there is no denial today that the physiotherapy, both passive and active, forms one of the immense, the fulcrum of the entire treatment of physiotherapy. I mean, the treatment of the frozen shoulder. People do get a lot of benefited with both home exercises and supervised followed by the home exercises. There's a lot of emphasis on the rotator cuff rehabilitation, especially once the pain has started going down. There's also a lot of emphasis on rehabilitation, how it can decrease the pain. Ashish has few days back taken a fantastic webinar on that. And so I'm not going to discuss that part because that itself needs 2 hours. But we will take the other aspects, key aspects, how they have been intriguing us. And when we conducted the survey, we wanted to know that who are the ones who are responding to us. So surprisingly, we have close to 75% people who had more than 5 years experience. You can see there are 57% people who had more than 10 years experience. So overall, this survey was attended by the people who had a credible experience in the field of shoulder arthroscopy. These people were performing almost close to more than 50 to 100 arthroscopies a year. And then there was a small group, which was about 29%, who was performing shoulder arthroscopy somewhere between 20 to 50. A very small group, 16 to 17%, was doing lesser number of arthroscopies. The idea was asking arthroscopy, shoulder arthroscopy was because when somebody is doing shoulder arthroscopy, it means he is a bit more into the shoulder segment. Otherwise, if I don't ask this question, this could have been even answered by the general orthopedic surgeons too. This was our first question. We wanted to ask that what do you prefer calling a frozen shoulder as? Do you want to call this as frozen shoulder, adhesive capsulitis, the good old term periarthritis shoulder, or frozen shoulder adhesive capsulitis, or it doesn't matter to them at all? And this was the surprise answer. The majority of the people, about close to 40%, loved calling it as adhesive capsulitis. About 25% people, if you see here, 25.4% people wanted to call it as either frozen shoulder or adhesive capsulitis. And the best part is, what is loved by ISACOS is only 16.2%. Having said that, the periarthritis shoulder was a very, very small group. So that is one good thing, that people are getting rid of this term, which conveys no meaning. But you won't be surprised. There was a recent literature review, which is published in the Shoulder and Shoulder Elbow Journal. Which is by the Abrasart et al. And what he said, even today, as of today, the 63% of the world literature still uses the term adhesive capsulitis. Then we asked another question: are you aware of ISACOS definition and the entire working what they have done with the frozen shoulder? So that was good thing that people were aware of the work done by the ISACOS definition and various pathological aspects of the frozen shoulder. So close to 67% people did respond that yes, they were aware. And they did not surprise me, because if you see, close to 50 to 60% people in this group were high caliber surgeons who were, having more than probably 5 to 10 years of experience. So somewhere or other, they would have come across this entire debate of the ISACOS. Now, ISACOS, as Ram very clearly has initially defined, this was the ISACOS meeting which happened in 2014 in Amsterdam, where they wanted to very clearly say that what is frozen shoulder. And there they use this classification: stiff shoulder is any shoulder which has got a restricted range of motion. But we need to be very clear that we are talking about a primary idiopathic frozen shoulder where there is no etiology. Secondary is anything else. It could be intra-articular, capsular, extra-articular, or neurological. And they said that this term should be used exclusively to define the primary idiopathic stiff shoulder. It develops without any trauma or specific shoulder disease period. However, if a patient has a condition that may be linked to stiff shoulder, but not known to specifically cause the stiffness, it will be still considered idiopathic. Because sometimes in some conferences or some meetings, we have a debate. So if there is a diabetes, should you call it as an idiopathic or it becomes secondary? So no, currently, according to ISACOS, if you have any etiology or any associations like diabetes, thyroid, dupuytren's, smoking, etc., it still falls into the category of the primary idiopathic frozen shoulder. One thing is very clear, according to ISACOS, that they are categorical about no to adhesive capsulitis. And the reason what they gave is because there is no adhesion. Though capsulitis is there, yes, there is some capsular inflammation, capsular contractures, but per se, there is no adhesion around. So if you put your scope anywhere, you won't find any adhesion. Yeah, you'll find the contracted tissues. So probably that's one reason they have said that we must not try to use this term adhesive capsulitis. Periarthritis is anyway gone. So
can I ask one question, Vivek?
Let me just finish, Ram. Okay?
Okay.
And then we'll come back to this. The second part, what they wanted to define regarding the global restriction of range of motion. So when we say global, what is the meaning of global? If the range of motion is less than 100 degree in forward flexion, less than 10 degree in ER, and less than L5 in internal rotation, they define it as a global limitation of range of motion, which is typically seen in frozen phase of frozen shoulder. It means if it is in so-called freezing or so-called thawing, we may not see this global limitation. Another definition, which probably you used, this came up with ASES. It's a consensus definition in 2011. 190 surgeons had participated, where they also were similar. So frozen shoulder is a condition characterized by functional restriction of both active and passive shoulder range of motion, for which radiographs of the glenohumeral joints are essentially unremarkable, except for the possible presence of osteopenia, calcific tendinitis. But in this latest review by Abrasad, they brought out a very valid point that this definition completely misses the pain. There is no description of pain. So they have modified this ASES definition, which is, if you want later, I can share this particular article, that primary frozen shoulder is a condition characterized by often severe shoulder pain and functional restriction of active and passive range of motion, in which radiographs of the glenohumeral joint are essentially unremarkable. So I think from here, we will start our rest of the debate, that one looks like we must be using our so consensus, if I have to say, we should start using the term frozen shoulder to have unanimity in what we are talking. Periarthritis shoulder is anyway gone. We must maybe start avoiding use of the adhesive capsulitis term. Reason is there are no adhesions, though there is some amount of capsular inflammation, but there are no adhesions. But this is one thing which probably I was listening to Ashish webinar, and this I made it myself, that whatever you say, it's a primary idiopathic frozen shoulder, maybe fine, somebody wants to say it's a frozen shoulder or adhesive capsulitis, the entire exercise should be to make all attempts to rule out a secondary cause, which is by either clinical method or investigative parameters, before you say it's a frozen shoulder, because a lot of conditions which could be because of rotator cuff tear, malignancy, inflammation, arthritis are blamed as frozen shoulder. So do all attempts before you say it's a primary. And I think we can agree with modified ASES definition. So now it is open for the debate.
Yeah. I think the key importance, as you described, is differentiating primary into secondary. Yes.
Yes.
Now, the question I want to ask is that you said even 65% still use adhesive capsulitis.
Correct.
Is it after 2015 ESACOS meeting or before?
No, this is today, even today. Because
the reason I'm saying is that periarthritis is ruled out,
no,
but still the frozen shoulder is used in the layperson term to call anything like a painful stiff shoulder. So that is the reason why I started to embrace the terminology of primary adhesive capsulitis in my usage to sort of reclassify them as a primary idiopathic frozen shoulder. That's the reason why I'm justifying calling as a primary adhesive capsulitis. I do take the point ESACOS doesn't want it because there is no adhesions.
No, that is what is their main contention. I think Yap and Amit Modi has raised the hand, so they can contribute. Yap, what is your consensus about this? Do you think should we be using the term adhesive capsulitis, or is it not right today?
Oh, well, I think both the terminology adhesive capsulitis as well as periarthritis of the shoulder, they date from the period when we didn't know what really happened in the shoulder. There was no arthroscope, and when it was opened, well, probably there are bursal adhesions, but there are no interarticular where the pathology starts. There are no adhesions. So both are obsolete terms.
Okay, Amit, you wanted to say something?
Yeah, I don't have an issue with the term frozen shoulder because that's the only term I've ever used. Now, I do have an issue about what Ram said about ruling out all secondary pathologies. because, you know, I think most people, the current practice would be if they come with a painful stiff shoulder, you would make this as a clinical diagnosis and do an X-ray at the most. But now if you have to rule out a secondary cause, are you going to start doing thyroid function tests, blood sugars, etc. for every patient? I think, you know, as a health professional, you have got to be conscious of healthcare costs, which are escalating all over the world, not only in India, but everywhere else.
Dr. Amit, one thing I'll interrupt. One is we have another questions coming on this. Second is, according to ISA cause, even if there is a diabetes or thyroid, smoking or any other issue, which are associated factors but not etiological factors, they are still considered under the primary idiopathic frozen shoulder. So when we say that it's probably the secondary, it's more of the inflammation, infection, tumors, or maybe, you know, rotator cuff tears, which you have seen. You know, sometimes frank rotator cuff tears where the patient is not moving, they have been blamed as a frozen shoulder. Or a 60, 70-year-old person who's got arthritis, who's not been moving his shoulder for last 6 months, you say frozen shoulder. So probably they wanted to say that.
Well, in these cases, we talk about stiff shoulder.
Yes.
Frozen shoulder is definitely, and I agree fully with you, Vivek, frozen shoulder is just reserved for the one where we couldn't find any reason. No reason, no pathology, no original pathology leading to a stiff shoulder. That is what we call a frozen shoulder. I think that makes sense for us. That makes it very straightforward.
So if...
Can I comment?
Yeah, Nilesh, you wanted to say something.
Yeah, so I think one thing is definitely the term frozen shoulder is very clearly been demarcated by ISACOS. Also, I think ISACOS has also mentioned that in addition to the diagnosis of frozen shoulder, the phase needs to be written from clinical follow-up perspective. That means, let's say if I see a patient in a freezing phase at my first visit, and if I mention that as a freezing phase, when the same patient comes to me 6 to 9 months down the line, it's possible that the diagnosis may remain the same, but his phase may have changed.
True.
So I think writing the sub-phase is important.
Okay, so yeah, Prateek, one quick. Prateek, mute. Whenever you people speak, just see that you are unmuted.
Sorry, yeah. Vivek, that means the systemic causes which are there, they all then become the primary, because all the systemic causes like, as you mentioned, diabetes, hyperthyroidism, so that the section from the secondary has to go, the systemic causes.
You see, they are associated causes. You know, there's a bit of difference between, let's say, SLE causing the SLE, which is a systemic disorder causing the stiff shoulder. Okay, let's say there's arthritis, rheumatoid. So then it becomes a secondary, whereas we are talking about just in associations, diabetes, thyroid, you know, they still remain the primary. Yes, Ashish, last, and then we move on.
So I agree. The semantic argument about adhesive capsuloid and frozen shoulder, that doesn't change the treatment. But I disagree that there are no adhesions. The reason the extra-articular arthroscopic release has been successful is partly because of that. It may not be in all patients, but you will often see that the subscap tendon gets stuck to the conjoint tendon, and that adhesion is extra-articular. That's why some of these extra-articular Bryceman hydrodilation do work. So we must not rule out that just because there are no adhesions, so there may not be adhesions within the joint, but these extra-articular adhesions because of a permanent internal rotation contracture, and those procedures which involve intra-articular release and extra-articular release are successful because of the adhesiolysis at the end of the day. The procedure is adhesiolysis.
Ashish will come back to this point at the end. Okay, we will debate this thoroughly. Yeah, Kush sir, last one.
It's just that sometimes there's a coexistence of rotator cuff tear, which had been asymptomatic prior to patient developing a frozen shoulder. So, you know, it may be secondary frozen shoulder. I think what we have to be careful is that frozen shoulder is an inflammatory process inside the capsule of the shoulder.
True.
All it does is cause the restrictions rather than actually worrying about the causes of why this person developed a frozen shoulder. We have to be very careful that it is the inflammatory process which gives the frozen shoulder name rather than actually any other cause. What is more relevant is the etiology or the pathoanatomy of the shoulder. And hence you be careful in using that the stiff shoulder is the one which is a frozen shoulder, rather than the cause of the frozen shoulder. If you do not have inflammation and you have a stiff shoulder, that is not a frozen shoulder. Is that, did I make myself clear?
Yes.
Yeah.
I think we have to be careful about what we're calling a frozen shoulder.
So we'll move on to the next one. In your experience, restriction of wrist movement is crucial in making a diagnosis of the frozen shoulder. And we had given these 5 options: abduction, rotation, abduction plus rotation, flexion and abduction, and all 3 of them. And this is what the response we got. Most of the people, that is about 38% people, according to Issaquah's definition also, it is actually the first one to go is rotation. So they thought it's rotation, followed by ABER and ER, which is usually I follow, that ABER and IR. And then there was a large percentage who thought that combination is the best. So I want to ask from all of you, which one do you prefer? Starting from Dinshaw, unmute yourself whenever you speak, please unmute yourself and then start. So do you take 3? So let's say I usually start with 2, abduction and rotation.
And so I think, Vivek, it's going to be different in different phases. So when your patient first comes to you in that initial phase of just capsulitis, the first movement is going to be rotations, internal and external. Then as the disease progresses in its natural history, it's going to come to a global loss of range, both elevation, abduction, all of them. So I think it depends on when you see it. So for me, I don't make that differentiation. Okay. So I would go based on what phase is it, and I'll note down which movements are lost, so that when he comes for follow-up, I'm going to try and see, has he actually worsened in time? Has he remained static, or is he actually a little better from movement point of view?
Sundar?
So from definition point of view, I don't think you require that, okay, only if this movement has gone, then he falls into the definition of a frozen shoulder.
But in your opinion, which one you have found most of the time? Because as you very rightly said, especially in the early phases, you will find the flexion near normal. But it's
so rotation, always rotation. Yeah.
Okay, right. Sundar?
Yeah, Vivek, I think the most important point is to differentiate the other causes when the patient has got come in the initial stages. Because most often, as you said, that they'll have almost near forward flexion and abduction. And the important steps to differentiate from the other causes like impingement syndrome or the rotator cuff disease, I think just rotation. I think most often is the external rotation. Usually I demonstrate even in front of the patient to keeping the both hands and demonstrate the rotation limitation that indicates that it's that starting stage of your frozen shoulder. Of course, with the disease progresses, patient will come with the global restriction. It is very obvious. So the early stages only it's finding difficult. So by rotation itself, then we'll know that we can rule out most of the other causes and we can point out this is a frozen shoulder and we can go ahead with it.
Do we all, because, I apologize because there are many slides, so we'll have to rush through few and, concentrate on few. Do we agree with this, that it is better in general to assess all 3, flexion, abduction, and the rotation, global restriction of the best parameter, but limitation in rotation, especially ER with the arm by side and IR, and glenohumeral abduction, where we actually stabilize the, rather than patient trying to use the scapulothoracic movement. That's the one of the earliest one. Is that okay with us?
I think it's because the frozen shoulder process will start from the anterior part of the shoulder capsule and sort of progress to the posterior part. You're more likely to see restriction in external rotation to start with. And then gradually as the capsulitis progresses, the areas get more and more painful. All those Christmas tree and the sort of the lava flow appearance inside the capsule will depend on which part of the capsule is restricted. So normally the external rotation, but one must keep in mind that you can do all of the movements, but to get external rotation, which is stiff, your scapula cannot go into your chest wall at the back. Hence, it's more restricted as compared to anything else. All of the movements of the shoulder are possible. You can glide the scapula over your scapulothoracic joint, but you cannot externally rotate because scapula cannot go inside your rib cage. But yes, gradually all movements will be restricted. But initial phase, all movements are possible but painful because the inflammation in the capsule, rather than actually they are restricted, what is painful. And then the fibrosis set in. And as the fibrosis set in, the capsule shrinks and you got a myofibroblast contracting the capsule, and you keep on restricting your shoulder movement more and more and more. Some will sort of get away with a very small amount of inflammation and they get better very quickly. Other will have a very intense reaction, intense synovitis, and they are the ones who suffer the most.
Okay, so we move on to the, yeah, Dinshaw, unmute.
Yeah, so for me, the real question here is that we know that in the initial phase, patients are going to have pain first, and then they're going to start getting loss of range. So you will sometimes see patients who have a classical night pain, they're complaining of only pain, and they have no loss of range. So they are just in the precursor stage of the so-called frozen shoulder. So should our definition really have loss of active and passive range as a necessity for the diagnosis of frozen shoulder? So what happens if a patient comes to you with just the painful phase just before he's lost his range? What would you call that? Would you not call that a frozen shoulder?
I agree with this. Actually, Dinshaw, I did read somewhere that there is a pre-freezing phase. You know, very few books and very few texts describe this pre-freezing phase, which I think all of us do encounter. So that's the time is somewhere looks like a rotator cuff tendinopathy, you know, some terminal it's painful, but some very, 5-10 degree difference sometime, but you say you don't know, is it the frozen shoulder, or is it the earliest frozen shoulder, or is it the rotator cuff tendinopathy? So you, as you said, okay, you put them on some medication, you call them at 3 weeks, then you reassess. If it was merely the tendinopathy, it starts subsiding and they never lose motion. But in the consecutive follow-ups, if they start losing motion, that's the first time we can define. I think the earliest part, which is very difficult, this is like first 2-3 weeks, they remain in the gray zone. It's hard to say, am I dealing with the rotator cuff tendinopathy, or maybe the partial cuff tear, those 10-15% bursal or articular surface tear where they can be just painful, or is it going to be a frozen shoulder?
But Vivek, that's like opening a can of worms, Dinshaw. Because the partial cuff tear, impingement, early slaps, and
no, that's what Ashish. Yeah, I mean,
discriminate those.
I think the most common presentation we see as a shoulder surgeon is somebody having shoulder pain for a while, not exactly dating one particular day. They say that I've been having pain for 1 month or 2 months, something like that only. They mostly come to us. So I don't know whether this pre-freezing stage is always diagnosable. But what I highlight is one thing. If the patient comes with a global restriction of movement and pain, better get a plain X-ray. That is going to be the next question, to check for calcific tendinosis. That gives global restriction of movement, and that is a cause for secondary stiffness of the shoulder, not frozen shoulder.
Okay, so I think this becomes the next question is a part of the definition, which is recently modified, that you should have a remarkable X-ray. So my question to all of you here is, straight away without we going to the panel, is there anyone, once you diagnose, let's say 45-year-old male, female coming to you with a frozen shoulder, you make a clinical diagnosis of frozen shoulder. Is there anyone who doesn't ask for an X-ray? Yes, most of the time they may not have any other secondary reason, inflammation or infection. So do you people always ask for an X-ray? Is there anyone who doesn't? Can you please raise the hand? Just raise the hand if you're not asking. Okay, Ashish is not asking. Anyone else who's not asking?
It's the first time we are seeing the patient, Vivek?
First time. Pratik, sir, first time.
Yeah, first time we will not, because you many times get patients.
Let me go to the second. He comes after 6 weeks. He says, I'm much better. So, and gradually he starts becoming better and better. So you will never ask? I mean,
then I would not ask, because when I see the patient first time, because not everybody can afford, and also there is an exposure, and I'm not suspecting anything else. I would just get an anti-inflammatory and the usual treatment. And if he comes back and he's not responding, and then I would go down the route to do an X-ray to exclude any other pathology.
Sundar?
I think it is important to take an X-ray, because no patient is going to come on day 1 or day 2. As Ram said, patient will come only after 3 weeks or 4 weeks. I think it's very important to take an X-ray to rule out not just calcification. It also rules out your secondary causes like arthritis. If the patient comes with the 50 years or 60 years, your X-ray is also going to rule out our secondary causes too. So in my practice, this is a referral center. Their patient is a tertiary center. So any patient comes here, always they come as a second or last opinion. So always I take an X-ray for any shoulder pathology. If they present with 3 weeks or 4 weeks pain, I take X-ray.
Okay, yeah. What is your...
Well, maybe we are living in a little bit different health system where the primary doctors is very responsible. Okay. And I've seen too many cases treated for a year or more for the stiff shoulder while they have an arthritis or even a posterior dislocation.
Correct.
So I teach the general doctor always to do a very cheap X-ray. I think it is mandatory.
So this is what our survey said. You know, almost close to 3/4 people wanted to do an X-ray, which includes us also. I mean, you know, somewhere we have burned our fingers here and there, you know, including me. It has happened to me. I told them, yeah, it looks like frozen shoulder. It did not respond next visit when they came. It was actually a glenohumeral arthritis. And I felt very, and history was not, you know, like, okay, over the years, history was only for 6 months. So after that, I made a point that I'm going to take an X-ray. You know, one simple X-ray is probably not going to hurt. Swanendu sir.
X-ray is mandatory for anybody coming with any shoulder pain. Might be shoulder, frozen shoulder or anything. X-ray is the primary thing that he has to do.
So should we say this? A plain X-ray should be done always to rule out any possible secondary causes and classify the current condition as primary frozen shoulder, because this is what exactly the definition says, that it should be, the X-ray should be unremarkable. Dinshaw, any point to add, or you agree with this?
I agree with it completely, but I'm very keen to know why Ashish doesn't do an X-ray. I want to know the reason for that.
Jadugar.
Right. I was hoping somebody would ask that. Fairly good clinically picking out these secondary causes, even osteoarthritis clinically. And whenever I have a faintest suspicion that it's going to be secondary, we do strip our patients, and we are very good at this.
Do you fall in 19%?
No. Suppose I think this is not going to be straightforward, or if it doesn't work out, there's no harm in doing the X-ray in 2 weeks' time. My busy OPD, if I send everybody to the X-ray and it's a hospital, I will never finish on time. And I think it's a radiation exposure. I compulsively see all of them at 2 weeks. So some of them at 6 days. So if I do the X-ray at 2 weeks, when I know that they are not responding, then it's still good enough.
Rashish, but theoretically, do you say that this is okay?
Not everybody has the same inclination clinically or the support service or the quick ultrasound service. So in the general definition, I completely agree.
Okay. So we move on to this, and I think this question I'm going to skip. If you have a change in your mind, you tell me that if the plain radiograph is normal, does anyone routinely does MRI or ultrasound? And this is what almost everyone thought, that they don't do it. There are very few people. If the plain radiograph is normal, do you routinely perform MRI or ultrasound to further confirm diagnosis? So there were about 19% people saying yes, but rest of overwhelming about 75% people do not routinely do MRI or ultrasound. So can I say this, that routine MRI or USG, if your clinical diagnosis is clear, if you have a normal X-ray primary visit, the MRIs and ultrasounds are not indicated. Do only if there is a doubt of a secondary cause. Is any point to make, Raghuveer?
First visit, I won't ask any MRI.
No, even if any visit, you know, he keeps on continuously getting improved.
If he's improving, I won't ask. But if he is not going to come my plan, if I want to go for any intervention, then I will ask MRI.
Okay. We move on to the next question. That is, we asked a funny question. Because there was some, you know, when we sometimes tell people that, do you know that the ultrasound can be done? So a large majority of people, you know, said initially, actually this part of survey, when a lot of seniors did not actually respond, it was actually 50-50. A lot of people said, no, we don't know that ultrasound can be done. But at the end, almost 75% people close to that said, yes, they know that ultrasound can be done. And my question to anyone, Ashish, other than you, does anyone does ultrasound? Amit sir, Amit, Yap?
No,
not as a matter of routine, no.
No, not routine. Like, let's say you want to confirm. So, if you have the equal opportunity of doing an MRI versus USG. So in UK, are you doing the ultrasounds to confirm?
Yes, I do. I do. A lot of my practice is ultrasound.
No, only for frozen shoulder. I'm talking only at the moment frozen shoulder.
To diagnose frozen shoulder.
Yes, yes, ultrasound is used, but not for a frozen shoulder.
Yeah.
Not for the frozen shoulder. Williams, yeah.
No, well, there are some cases where I consider it. Suppose you have a 45-year-old guy with a frozen shoulder, and he might have a cuff rupture, and he's a laborer. And we know now that you can repair a cuff even with a frozen shoulder, the same results.
No, yeah, I'm not talking, we are not bringing any cuff issues. Especially the full thickness. We are talking, do you ever perform the...
No.
Okay. Anybody in practice who's Ashish other than you, I'm sure that you must be doing, and you have already got a study going on. No one. Okay. So this is what actually we have done a study. It has gone now for publication, that ultrasound along with power Doppler can be used as a screening tool to diagnose frozen shoulder and also rule out secondary cause. Like Willem said, there can be sometimes the rotator cuff tear or bursitis, biceps and all. And what exactly to look for is actually to look for coracohumeral ligament thickness. It's a very sensitive sign which can be picked up on the ultrasound. So the range they have given is something like 0.7 mm to 1.3 maximum mm. But you have to compare with the other side. Other things which are frequently seen. So this sign, which I have underlined as very sensitive, it could be about 85 to 90% cases. Whereas rotator interval echogenicity with increased vascularity in the rotator interval and wherein you use the power Doppler is about sensitive is about 30 to 40%. So not in all cases you get. The vascularity in rotator interval is increased usually in the freezing phase when there's a lot of inflammation going on. But as it moves to the frozen part slightly, the vascularity decreases. What you end up is only the CHL thickness. So there are a couple of studies which have come up of late, and they say it can be used especially in this setup where the finance can be an issue. Ultrasound is a good screening tool, and I think Ashish can throw some light on this.
Yeah, it's easy, no radiation, and MRI can be an overkill. What I'm trying to say is that if you just segregate the frozen shoulder patients from your practice, don't include all the others, and of how many MRIs are normal, how many X-rays are normal, you'll see a surprising bulk of them coming back normal.
Absolutely. Absolutely.
MRI has nothing to add to the diagnosis. In fact, the MRI findings are surrogate, the capsule getting tighter and not seeing the inferior pouch. Otherwise, apart from that, the MRI doesn't give you any information.
So,
Vivek, my question is, if you suspect secondary pathology, you're going to go for MRI, or you're going to go for any contemplating intervention, you're going to go for MRI. So if for a primary confirmed clinically diagnosed frozen shoulder, what is the additional advantage of doing ultrasound? I know ultrasound is good to pick up.
Ram, give
Just
me
want to confirm it.
No, give me a reason.
Vivek, I will give the reason for the same vein.
Okay.
What Ram asked, because you are doing ultrasound just to confirm the frozen shoulder, and we know if you rule out the primary cause, secondary causes by X-ray and your clinical evaluation, for the frozen shoulder, you are going to treat conservatively. Unless you need an intervention for that frozen shoulder, then you want an investigation to rule out those secondary causes. So what is the advantage of using ultrasound rather than MRI? What I'm saying, why I'm not saying MRI is better?
No, I'm coming to that, Sundar. The next slide is about that. You see, I'll tell you what is the reason. Swanendu sir, just give me a second. Why we do ultrasound? So I also do not, point number one, we do not do a routine scan, whether MRI or ultrasound.
Yes. Correct.
Two, as you very rightly said, if we are planning an intervention, let's say I have to give an injection, in our institute, we give the ultrasound guided. But when I do that, when I have a doubt that is there a partial tear, the tears which are 30-40%, when you're testing that there is a partial tear. Now in partial tear, I don't want my patient to be subjected to a harrowing experience of, in the MRI, the gantry is not a very pleasure thing. So I usually send them, and whatever report I get, then I decide. Like, let's say it says 80% tear. Now that 80% tear bothers me. Then I send them sometimes for the MRI. But if just says 20% bursal surface thickness tear in the middle third or posterior third fibers of the supraspinatus, then I'm sure that it's a small partial thickness cuff tear with a secondary frozen shoulder. And in those cases, I'm a bit skeptical of injecting. So that's the reason we subject them sometime to the scan.
Vivek, can I come in here?
Yeah, Nilesh.
Yeah, I think whatever you said, everything holds good, provided one important thing that it is user dependent.
Absolutely.
So let me put it in perspective. I work in a different institute as Dr. Babulkar, but even then, if I have to do an ultrasound to be done, I send it to Dr. Mrs. Babulkar because she's extremely good, and I can correlate her findings straight to an MRI. But I can't say the same thing would hold good with any other sonologist. So I think if you
this is what it answers, Nilesh.
Yes.
Yeah.
This is why. So we knew that this is what is the next step. That why, if I have to do, why majority of the country or the world wants to do the MRI, because the ultrasound is a user dependent.
Absolutely.
Very few institutions remain. They have a very good sonologist, okay, who can almost impeccably match the non-laboral issues. You know, anything outside, cuff, biceps, anything else they can show very well.
Yes.
Today, I mean, even if I have a doubt on something else, I know that there's something else, then I'll go for MRI.
Yes.
Right. Perfect.
I think that should be the key message. If we are suspecting secondary pathology or contemplating intervention, you better go for MRI.
Yes,
But
so
in a case scenario where you have you're dealing with the isolated primary frozen shoulder and you want to confirm, it's a good idea to use that.
So this is what it says, that ultrasound can be used as a screening tool to diagnose frozen shoulder or rule out some secondary causes, you know, like partial thickness tear, articular side tear, biceps. If a good MSK sonologist is available, that's the primary, I think, requirement. But if you don't have, then MRI is overall better tool to diagnose frozen shoulder in addition to all coexisting or contributory intra and extra-articular pathology. Sundar, have I answered? Sundar, unmute.
I have some disagreement, because even if you diagnose a partial tear of the cuff with stiffness, the problem is whether you're going to intervene that for that partial tear or not, because we have a lot of debate, even the partial tear to operate or not to operate, whether 40% or 80% still people go and do just debridement and come out. So still again, it comes to the stage where you need an intervention. Unless you need an intervention, you don't need any investigation for a frozen shoulder, even in ultrasound, to just diagnose a frozen shoulder. So basically you want to rule out the secondary causes and you want to intervene. So when you want to intervene, whether it's a 40%, 60% doesn't change. So better to do an MRI so that you know more your quality of the cuff, everything, even the chronic tear with the secondary stiffness, your MRI gives more information rather than ultrasound, like the quality of the cuff.
Ashish.
I need to make some very important points here. And I agree that the local setups are very different. Your ability of expertise is very different. Apart from the fact that we are a very cost-sensitive country and the ultrasound is 1/10 the price, let me reiterate 2-3 very critical points. Number one, a calcification can parade itself like a frozen shoulder. An MRI will miss calcification more often than not, especially if it's a non-3 Tesla MRI, which most of the country doesn't have. An ultrasound will remain the superior investigation of choice. I say I'm imaging agnostic. I don't like too many investigations until the patient is not doing well. So most of them don't do any investigation, forget ultrasound. When it is a time to intervene, my practice of arthroscopic adhesiolisis has minimized significantly. I will do an intervention on ultrasound doing a HVI. So in my case, that is my intervention, where I do a high volume injection, extra-arterial injection. The third point I would like to, Sundar's point is very valid, but let me bring in a very important caveat. MRI will always over-report. The chances of an MRI reporting a partial cuff tear and the chances that a novice surgeon will go in and operate are much higher because he has given credibility to the MRI radiologist report, failing to read the MRI themselves. That would never happen with an ultrasound. So when you are in serious doubt, get both of these things done, but be dead sure that it was a near full thickness tear and not a partial tear, which is a reported tear. It is not factual tear. Very often youngsters, fellows have gone in, put the scope, not seen anything and come out.
So can I interrupt for a second? So but most of
Neeraj, just again, Swarnendu sir, then you come. Yes, Swarnendu sir.
Yes, the thing I was completely agreeing that Ashish is telling, MRI is an over investigation for this thing. If you are worried about the quality, the who is doing the USG, even the machine is also important for the MRI. And MRI is always over report in the frozen shoulder. So my first investigation after X-ray is only the USG in good hands.
I've just drawn a small diagram. I think this is what Ashish was trying to say. So just imagine this is supraspinatus. A is anterior, P is posterior. If the tears, in many cases of these partial tears, they are actually located, a very small partial bursal surface tear is located in mid-third or posterior third of the supraspinatus. And if you go and try to, and they'll be like 30% of bursal surface tear, 40% of articular side tear. If you try to go and operate, they are a mess. Biomechanically, if the tear is in anterior third here, which is where the anterior most tendon is there or anterior most cable is there, those are the ones which are very significant. And somehow, if you have a good sonologist, this can pick up very well. And he will tell you exactly where is the tear. Is it in anterior third? Is it in middle third? Is it in posterior third? So the tears which are partial, which have got the stiffness, but they are in middle and posterior third, they can be ignored. Again, you can use this Burkhart's cable theory. But the tears which are in anterior third, even if they are 50-60%, they will continue to bother them.
Yeah. Let us.
Okay. We've got a lot more to go. So, and keep your poll ready now. So the question is, RBS in HB1AC, if you have a doubt, which is the screening blood test of your choice? So I'm going to ask you a question. Let me just put this a little below. So this is your question. A 45-year-old male comes to you in OPD. He is having right shoulder pain since 4 months. And you have made a clinical diagnosis of frozen shoulder. There is no family history of diabetes. The last RBS done at some center in India, we can understand some center, was 136 milligram, which is 4 less than the higher side. So the question is, should you do the RBS Glycb? No, I won't repeat. Very interesting. Okay, fantastic. So we have a very divided house. Where is Babulkar? Ashish boss? Gone, looks like gone for a tea. Okay.
No. I have voted, but it's a slow internet here on my mobile.
Okay, all right, fair enough. Okay, so the overwhelming 60% feel that it should not be repeated. Let me go to the next one. And this is what the survey actually said, that 66% people, when they were evaluating a routine diabetes, routine frozen shoulder, a 45, 50, we know that these people often are diagnosed frozen shoulder in the OPD, the diabetes in the OPD, either they are pre-diabetic or they are diabetic. So Mayer RBS, it has happened in my hands also many a times that Mayer RBS has fooled me. The RBS was 136 and I thought it's not. When the things did not respond to my conservative treatment after 6 weeks, we did their Glycb also. Glycb came to 7.1. And his RBS remained in 150, 160, which can be still managed with the conservative treatment. So I don't know, over the years, I have been doing RBS and Glycb. I'll show you some literature review also. Wherever it is pertinent, I'm going to show you the literature. What does it say? But why, I know why the house remains divided.
No, I voted for also HbA1c glycated hemoglobin, okay, because in my practice, I see quite a good number of patients come with their shoulder pain, and that is when we detect diabetes. It's the first presentation for a significant number of diabetes. So last RBS doesn't give a clue. Family history doesn't matter. We are a diabetic capital of world. So we have, in my practice, I do glycated hemoglobin as a routine.
So Dinshaw, what is your take? You do these 45, 50s, do you always do the glyc or you don't? You would believe that 136?
Always do it. So I think in India, we've got a lot of diabetes and a lot of these patients are actually known diabetics, so that's fine. But if someone comes with a diagnosis of frozen shoulder and he says he's not a diabetic and he hasn't got his test done in the last 6 months to a year, I'll straight away get a glycosylated hemoglobin done.
Okay, so let me put this little statistics.
But Vivek, but here already patient has come with the blood sugar result, 136. 136. Why do you want to repeat again?
No, I think a glycolase rate, yeah.
I'm coming to that, Sundar. Okay,
Okay.
so 10 to 36% risk of diabetes in patients who have got frozen shoulder. And this is the latest study. See, I went through many studies, but this is one study. Is it necessary to screen the patients with adhesive capsulitis of shoulder? See, this is, Ashish was asking, this is as close as this is, I think, 2000, one moment. 2019. Okay, no, I'm
2019, the topic doesn't listen to ISACO standard, calling adhesive capsulitis.
135 patients with IAC. No, this is, I think, an Indian study. 135 patients with IAC where they did fasting PP also. And they found that the 15% patients were pre-diabetic and 27% patients were diabetic. Okay, and all these patients were actually, when screened with RBS, they were all normal, okay, or borderline. So there, this thing is that patients with frozen shoulder must be screened for diabetes. The literature is always funny. This is another study which is published latest in the JSCS in 2017. And they also said as the glyc-HB keeps going up, the chances of frozen shoulder keeps going up. But they have done a study on close to 20,000 plus patients. And another surprise, look at this JBJS, JBJS, what they said, there is no association found between, and this they had close to 2 lakh patients. The retrospective analysis, and they found no association between HB1AC level and the prevalence of frozen shoulder in this diet. So it remains a bit diverse, but my personal opinion, I have found that I have myself personally missed a lot of pre-diabetics and just the diabetics when I did not do glyc-HB. So off late for last 7 years, I've been doing glyc-HB mandatorily. I don't know what's the house's opinion.
Mandatory.
So
definitely mandatory.
So Vivek, Vivek. So let's say you do a glycosylated hemoglobin, and let's say it's on the higher side, or if the patient is pre-diabetic, is it going to change your management?
Yeah, Nilesh, I'll tell you how it changes. So let's say somebody has got a because less than 5.8 is normal glyc-HB, 5.8 to 6.4 is pre-diabetic, and 6.5 onwards is diabetic. So if somebody has got, let's say, 6.3, but his RBS is, let's say, 138, 139, I'll just advise them, and it has happened to me in my practice, I advise them diet control, nothing else. Apart from the treatment of frozen shoulder, he's just on diet control. Nothing else, no treatment is required.
Yeah, I think Neil's question is whether the treatment of frozen shoulder is
treatment of frozen shoulder. Yeah, treatment of frozen shoulder.
Yeah, it's not different, but
but the minute they cut down their routine sugars, you will find a drastic change in just 2 months' time. I mean, it has happened to me. So that's why I have put up this slide. I wanted to know people's opinion.
So I've seen in uncontrolled diabetics, proven diabetics, when the sugars are high, the pain component seems to be a little higher for unexplained reasons. And when that sugar control is better, fair enough. But
you see the second point, patients with worse blood control sugar over a long
time. I agree on that point.
Okay. So those who are diabetics, we all know, but the question is the way diabetes have been hitting our people. I don't know about the probably Netherlands and UK. I have no clue. But what I felt in our practice, the incidence of pre-diabetes and diabetes has been dramatically increasing. And I myself have missed close to 25-30% people in the past when I did not do glyc-HB. So now it is mandatory we do that. Yeah, Raghuveer sir.
So should not ask regarding hyperlipidemia at this stage, because I have seen in young patients as 25 years or 30 years, hyperlipidemias, they are coming with frozen shoulder.
I agree. There are many associated factors. This glucose, thyroid. So let's go to the next one. So do you routinely perform thyroid function test, at least TSH, if you encounter a woman who has got frozen shoulder? And this is what we had given the option, and this is what the survey said, that 40% people in a women, and I'm talking about, see, when you have a clear symptom of weight loss, weight gain, or some, temperature different or something else, which is, or maybe there is a thyromegaly, and most of the time they are all having the thyroiditis, which will usually not give you the typical thyromegaly. Some of them may have, some of them may not have. So, but what is the opinion here? Who is doing the, you know, I don't know whether I should put myself in 40 or I should put it in 29 also, that whether in doubt. So in women, I don't hesitate in taking the TSH. I just want to have one TSH. That
routine.
Yeah. Routine.
TSH is mandatory for me. Vivek, TSH is mandatory for me.
TSH mandatory, Ashish, Ram.
Ultra TSH, predominantly females. 90% of these patients are females, hardly thyroids in males.
Yeah, male, yes, of course. I also don't take in male. Sundar?
Yeah, I also do only when there is a clinical manifestation. I think it's a good idea to do the TSH to rule out hypertension. I think it's agree.
Unmute.
So most of the patients who come to me already get their, health studies and all that done. But if they don't have a TSH in the last 6 months, they need to get one done.
Okay, so let me put this one. So this is a latest study published in the JSCS and as well as in the Clinical Endocrinology in 2003. There's a 27% prevalence of hypothyroidism in patients with frozen. See, it's almost matches to the diabetes. So these two key factors need to be probably more and more, center studies are required. But I feel that, if you miss this 1/3 of the group who's having diabetes, thyroid, that thing continues, they don't get responded. And then when you do it after 6 to 8 weeks, sometimes you feel sorry that I could have done it then. I don't know what is the expenditure on the, what kind of expenditure it will on healthcare, especially this is pertaining to the UK people, Amit sir and Kush sir can say, but in India, we don't hesitate in taking.
Vivek, ask the opinion from UK, what they're doing.
So Amit sir, what do you do? So would you take or no?
Also, yeah.
Oh, well, my policy is to report to the general practitioner, who is the caretaker of the patient, to have a very low threshold to do the TSH and also the.
Okay.
I personally don't get involved. As Job said, this is not our responsibility. We tend to stick to the orthopedic side, and then the GP will do everything else.
I think it's automatic evaluation by GP there.
Maybe in our Indian scenario, with looking at all of you, I can say that in a women, thyroid evaluation is perhaps recommended. If you have, and especially if you have a slightest of the doubt, a bit bulky, a bit obese, even if they are not manifesting all symptoms, it may not be harmful to do one TSH. Okay.
Would that change your management? If patient has, dysfunctional thyroid, they have diabetes, they have hyperlipidemia, would you manage your frozen shoulder any differently?
No.
The prognosis changes. So the last slide,
I will not repeat afterwards that I have not diagnosed this thing. Whenever the patient has come to me, I will not going to repeat that I could not diagnose his diabetes, I could not diagnose his thyroid, I could not diagnose his hyperlipidemia.
I agree, Swanay.
I don't want to regret.
No,
yes, what happens, that is being nice to your patient rather than actually being an orthopedic surgeon. But I agree.
Amit sir, you wanted to say something?
Yeah, I want to say, with this diabetes and thyroid, they are known risk factors, but I don't think there has been any study which shows whether your diabetes control or your thyroid function control has a bearing on the outcome of a frozen shoulder.
Let's leave it to the last slide. I'll come to this. The last slide of the day will discuss this. Okay, now this is going to be Ashish.
Yes.
Okay, so do you follow the 3 clinico-pathological staging system while treating your patients? And this is open for you all. Please go ahead. While treating your patient, are you following this? I'm not saying whether you pathologically, whatever, believe or not, when you treat, do you follow this? Okay, so a large majority people believe in the this staging system to do the treatment. I'm sorry.
90%, is it?
Okay, so almost 89 to 90%, and let's say what survey says. So the survey says close to 70%, 65 to 70% people believe There are about 20% people who do not, 13% do not believe, and some do not follow this system at all. I mean, maybe they are just treating it, they are not following it. So what we went through the literature, including the ISAKOS literature and the latest literature, according to them, there also worldwide, overwhelming people believe in this staging system, because this is how the pathology has been explained also. And I think Dr. Kush was trying to explain this. Yes, it is true that although clinico-pathological staging does not follow a strict course, because it keeps getting changed as you change your treatment. You give an intra-articular steroid, the freezing phase comes down. But it might help in deciding the treatment plan. So somebody who is in, let's say, the frozen phase, that's the time you want to do release. Somebody's already gone into the recovery phase, then you don't want to do anything. So it helps in explaining or discussing a probable or a reasonable course of disease with patient. So do you think I have framed a reasonable statement for this?
Yes.
It just helps in probably discussing with the patient whether, it really follows that or not. We don't know, but it helps me in explaining to my patient that, okay, now he's somebody who's in thawing. So I can say, okay, you are recovering now. In another couple of months, you might be all right.
I think that's exactly 100% true in my practice, because number one, to explain to the patient and also guessing the prognosis, timely intervention. And most important thing is the freezing stage to frozen stage, because the freezing stage is the one with the pain, and you shouldn't do any of the intervention during that stage, like whatever hydrodilatation, MUA, arthroscopy. I have seen being done complication coming up.
We'll have that.
It is important to progress freezing to frozen and thawing phase as a line of management guiding.
Ashish, yeah, you wanted to.
Let me clarify things. There's no denying the 3 stages exist. The problem is the time interval that has been described, and none of the patients follow that time interval. So
that is true. That is true, Ashish.
No. So the question would have been better framed is, do you believe that the stages follow? What happens is it can lull somebody into complacency by saying that, oh, you're in the freezing stage, it's a matter of 3 months. You understand? The features of the 3 stages are valid. What Ram mentioned was never operate and avoid operation in the freezing stage, which is when the patient is begging for intervention.
Yes.
Last thing was, even if it's a recovery phase, there are patients who are stiff and not painful, and they will require surgery to restore their function and restore their range of movement. So I don't mind operating in the recovery phase if they have hit a plateau. So those are the caveats that we must understand. So don't follow it unblock, true to purpose. Nothing is cast in stone. There are many patients who have overcome the freezing stage within the week and then moved on to the next stage.
No, that is what Ashish, the first line says, that it does not follow a strict course. Each patient will have a variable course, and it keeps getting modified with the interventions, or some people may have, let's say very, very severe diabetes. Their freezing phase will be very, very violent. They are in terrible pain. Okay, so guys, we have next question, a bit funny question. And this is what is the survey result. So what time do you prescribe the NSAIDs or other analgesics in frozen shoulder? And we said, okay, morning, afternoon, night, at bedtime, or time doesn't matter. So a large majority of people, about 70%, 65 to 70%, giving the analgesic at the bedtime. And rest are, divided between somebody said time doesn't matter, morning, afternoon. Now, the rationale behind this question comes now. So please be ready. This is, I think, the third one. So if you can answer this question. And that's the rationale. We wanted to be very clear that if at all you are giving, maybe it is rational to, why should we give an analgesic at a particular timing, Okay. So, I mean, it is anyway described in definitions also, and we have very categorically demonstrated, almost online, that by and large, the pain is at the end of the day, or especially in the nights. It really disturbs the sleep. So even we had this situation where patient has come back with some medications given in mornings, not in the night, and patient continues to be in terrible pain. You just switch the timing to night, and they come back after 2 weeks, they say, I'm much, much better, because when it hurts most, they should be on a analgesic. So in our survey, the 65% surgeons felt that NSAIDs or analgesic must be given at night to avoid pain. Do you think this is okay? It might be prudent to add analgesic in night at bedtime to avoid the disturbing night pain and give them better relief?
Yes.
Or do we have any diverse opinion from this? So we can take this statement that it is much better in frozen shoulder to give them painkillers, whichever you decide to give it in the night, rather than giving in the day when it is, because daytime you ask them, they say, I'm fine, I don't have a problem in the day. The nights are terrible.
Well, it is.
Sorry.
Yeah,
go ahead.
Yeah, it is so interesting in orthopedics. Actually, it is the same as in osteoarthritis. In the night, there's nothing we are thinking or doing about. During the day, many of these patients, both osteoarthritic patients and frozen shoulder patients, they adapt their activities, and being busy with other issues, they don't bother too much about the pain. So it is quite interesting, more or less psychological phenomenon, that the pain, it might be as severe during daytime, but more felt during nighttime. But totally, I agree with your advice to be very liberal in analgesics for the night.
Okay.
Patients are really bothered.
So also, Vivek, just a quick comment. So I think Issaquah's has mostly, other than Issaquah's also, there are many other studies which have shown that NSAIDs do not change or alter the natural cause of frozen shoulder.
Correct.
So it's purely for symptomatic relief.
Absolutely.
So what I tell my patients is, don't take them every night, but when you feel on an SOS basis, you're okay to take it, because you're not looking at the anti-inflammatory action, you're purely looking at the analgesic action, because the natural cause is not going to change.
Very true. So most of the studies, I did not quote it here, but most of the studies have failed to demonstrate any change in the course. Having said that, let's take a poll here, a hand poll. How many of you give the analgesic, sustained release, or any form of analgesic of your choice for, let's say, together for 7 to 10 days? So I'll raise my hand. I give it for together for 7 to 10 days. And then I say SOS. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. No, but Nilesh, you said you give.
So initial. So when you mention analgesics, what I give is I give pregabalin. So I give a neurotropic drug for pain relief.
Nilesh, I'll come to that. That's
okay.
The next question. Okay. We will come back to that question also. Okay. All right. So next is the, there comes the, I'm going to poke now, Ashish. Okay. If the pain, no, Amit, you raised your hand. I'm sorry. Yeah, Amit.
Yeah. I'm not sure about the relevance of this question, because most of my patients, I find they're taking some sort of analgesia around the clock, because the pain is quite intense. The pain doesn't come in the morning or evening. But what I do tend to add is they add some sort of opioid at night time. So it sees them through the night. So daytime, they can take what suits them really.
Okay, let's take another poll, the last poll for this question. How many Indian surgeons add any kind of opioids? I'm not talking about the synthetic ones, let's say tramadol. I personally have very rarely, unless I have a contraindication for an NSAID, I have not added tramadol in any of these patients. So how many of you even add synthetic opioids? And how many of Indian patients have ever required a opioid level analgesic in a frozen shoulder? So Amit sir, we have a slightly different practice maybe here.
Well, I think, opioids are just in a way safer than your NSAIDs, I think. I'm not saying tramadol. You can take something as simple as codeine phosphate. And I can tell you from personal experience, it works like magic.
Which one, sir?
Codeine. The codeine.
Okay.
Codeine phosphate combination is liberally used in UK.
Yeah.
Not very much in India. I used occasional tramadol for the night pain.
Yeah. Okay. Now, yes, this is open. So if pain fails to respond to NSAID, what else do you add for pain relief? And I'm going to just show you this survey. Almost 70% people wanted to give a steroid injection, in specifically intra-articular steroid. So this is probably, we are talking of those bad pains of freezing phase. I'm not talking about the late frozen or the early thawing. 15% people wanted to give a subacromial steroid, and rest is a very diverse thing. Physio, suprascapular nerve injection. Thank you, Nilesh had suggested this. Physio, nerve block, rehab, physical therapy, and then, the very limited, about 3% people wanted to give the oral cortisone, and about 1.4% physiotherapy, and less than 1% is pregabalin. I wanted to have a survey on this, but I thought I'll ask, how many of you actually add ever pregabalin? 1, 2, 3, 4, 5, Ashish. Okay, and what is the rationale? Do you have a, I also add, but I'll ask you, what is the rationale? Is there have a special group you add, or every patient with frozen shoulder you add? And let's not confuse that they have a cervical symptom and you want to add.
Every patient I add because this has got a dramatic relief to the patient.
Okay. Sundar, do you add? Unmute, Sundar, unmute.
Yeah, especially I prescribe for the females, especially as you see in the freezing stage, they have acute severe pain. And these patients are well, and they say that they're not just pain in the shoulder, they say that all over the pain for the shoulder radiating to the arm, because it's not typically in the shoulder. So whenever the patient says that pain all around the shoulder and radiating, I add the pregabalin, and they have a good, very good result.
Rinshaw, unmute.
Not unless there are any neurological coexistence symptoms. So for a primary frozen shoulder, no.
And to your surprise, you know, you won't find much literature on the pregabalin in frozen shoulder. Hardly. I mean, maybe I missed some research. There maybe is definitely something. I could not find much. So I also usually do not add as a routine, but I give them sometimes when there's a little bit, I have a doubt of neuralgic pain or diabetics. Sometimes I add, but I have absolutely no, the data to say whether it helps or does not. Gentlemen, just give me 1 second.
So if not the pain, I think the pregabalin makes them sleep much better.
Sorry, stick to simple codeine.
What is your opinion?
Codeine, unfortunately, Amit is not available here. That's my biggest contention. I would love to give codeine. I'd love to take codeine.
Okay.
Amit, what you are doing with pregabalin in frozen shoulder there in UK?
No.
I have never used pregabalin for frozen shoulder.
The house remains divided. It's more of a personal choice, but I can't really recommend as the consensus.
Yes.
Okay. So this is what is the overall I have found in literature. I am going to quote almost everything. Injectable steroids are a good option if primary measures, which is NSAID or any other analgesic like Sir said, codeine or physio, some physio has failed. Now these are few literature which I wanted to quote rather than having a debate. Intraarticular versus subacromial, surprisingly, the results are similar. There is one systematic review which is published recently by Shang et al. What they found that the pain is dramatically less in all intraarticulars, but range of motion is slightly better in subacromial. And the logic they gave is, since majority of the inflammation synovitis is it in the joint, so when you give an injection, it reduces drastically. Whereas when you give a subacromial injection, the drug kind of remains more outside, affecting the capsule and tendons from outside, which I could not understand. But they have found that the range of motion is slightly better in subacromial. But if you read individual series, intraarticular fares always slightly better than the subacromial.
Did you take a vote on intraarticular or subacromial in the panelist group?
Okay, let's take here only. Let's take here how many for intraarticular, how many for subacromial. Intraarticular. 1, 2, 3, 4, 5, 6, 7. So almost 7. Anybody for subacromial? Okay, let's have the subacromial.
Vivek, just another extra vote. Never subacromial.
Never subacromial. Okay.
I give both.
Okay.
Vivek, anterior approach or posterior approach?
Approach, sir, we wanted to avoid because there were too many questions. Okay. The one good thing what I found, though the efficacy, so-called efficacy of oral steroid is also similar. Okay. But I think it is better to avoid because injectables give you the similar efficacy and they are local. And in the oral, when we did the literature, there is a bit of a rebound risk. When you stop the oral steroids after 4 to 6 weeks, there is a bit of rebound, which is not actually seen much in the injectable. And there are many published literature of avian hip, even with the shortest of possible course. Even if you give for 6 weeks, there is a risk of avian hip. So can we have debate on this last point, rebound? And Amit sir raised a hand. You wanted to say something, sir?
Yes, Vivek. I think, a lot of these injection things, what we do, it depends a lot on how you have been trained and what your experience is rather than evidence. Because I have read a paper which says even you inject in the buttocks, it has the same effect as injecting subacromial. Honestly, I'm not joking there.
No, I'm sure that you must have. I'm sure, sir. Yes, sir. So,
the question is, what about oral steroid? That's right, Vivek?
Oral steroids, anybody for here? I mean, I have never given and I would not recommend any oral steroids when you've got the similar.
It should not be recommended, Vivek.
Absolutely, sir. Absolutely. That's why written orals can be avoided. Now we go to the next point of injection. Ashish, you have got anything here to say other than the approach?
No, I rarely give them. But if I do, then I prefer the steroid intra-articular anterior approach.
Okay.
Definitely not oral.
I'll come to your point, which we had discussed in past. So, which is your preferred drug? So, previously, I myself was using methylprednisolone, and I'll tell you how I gave up. But now we are using triamcinolone. So, we gave 5 options total, 40-80 and 40-80 of both molecule. And there was a group who never gives an injection. So, we thought we'll respect them also. And this is what was our survey result, that majority of them, they give, you see, there's something very funny. A majority give actually 40 milligram of the triamcinolone. But when they give methylprednisolone, their numbers are 80 milligram. Okay, and then you have got the divided house between the others. So previously, I want to see that what is your opinion. Previously, we were giving methylprednisolone, but I had more post-injection pain with methylprednisolone as compared to the triamcinolone. However, we were giving, so we kept on giving once our pharmacy ran out of the methylprednisolone, so we started giving triamcinolone. And then I realized that for next 2 months, none of my patient came back with the post-injection pain. And then I completely switched over to triamcinolone. So is there any similar experience with you? I don't know.
Do you know the reason why that happens?
No, Ashish.
It's because it crystallizes. Triamcinolone is the only one that doesn't crystallize. Whereas methylprednisolone, if it crystallizes, and especially if you mix it with an lidocaine or lignocaine, crystallization causes intense pain.
Raghuveer, sir, you have any similar or any experience?
Yeah, triamcinolone is a long duration of action.
Which one?
Compared to because triamcinolone long duration of action. Duration of action is more.
Okay. And so in the literature, it seems to be, so not only by the survey, it seems to be the most, the closest drug which is preferred by people is triamcinolone. Anybody now giving methylprednisolone in our 12 people? None. Okay. All right. And 20 milligram, there are many studies which have said that 20 milligram triamcinolone has no difference with 40. So the recommendation is keep it lower. But if you use 10 milligram, it is not effective. So 20 would be probably an optimal and 40 is not a problem. And the performance of triamcinolone has been better in diabetics. Many studies have proven. This is one study I've quoted. And this is one study by, I think, one of the Indian studies. There are better pain scores and range of motion with triamcinolone as compared to the methylprednisolone. So maybe we can take, though there are not many, many comparative studies, but overall it says that triamcinolone seems to be faring better as compared to the methylprednisolone. Now comes a little bit contentious issue. How many, there are blind injections using just the landmark, as Ashish was anterior, posterior, fluoroscopic guided or ultrasound guided. So how many of you are giving blind? 1, 2, 3, 4, 5, 6. Amit sir. Okay. Rest of us. Yap, do you give blind injection or do you give ultrasound guided?
Blind injection.
Blind injections. Okay.
Yes.
So this is what looks like here also. Almost 60 to 70% people give blind, which is almost 70%, and very few give fluoroscopy. After this thing is ultrasound guided, which is about 16%. But let's see whether there is difference or not. So most surgeons prefer blind technique. Why? Because it is easy, quick, it's an OPD based, and most of them do not have a musculoskeletal, sonologist. Not everyone is lucky like, marrying a sonologist like Ashish Babulkar. Okay. However, if you read the literature, the accuracy and efficacy of the guided methods across the literature, across the systematic review is better. But I want to know your opinion. All of you are giving, all of your patients also doing well. Have anybody done a study to compare your groups? Push.
No, we haven't compared. It's just my practice to do it myself. Depends again on the radiologists as well. Not all are as gifted or talented as the others. The studies are all about general practitioners. I don't know what studies you have come across. Most of them are done in general practice, and the studies are the general practitioner doesn't do as many injections. I can personally say I will not allow a patient to go out of the room till they tell me they are pain-free. So at least my local anesthetic is working, even though steroid does or doesn't work. If you know that you given local anesthetic at a site of pain and the pain is gone away, you've done it right, or as near right as you possibly can be. But I don't believe in studies because these are all sort of primary care studies and they're not really comparative studies with the secondary care. So I think you've got to be taken with a pinch of salt. But our policymakers in the NHS will make policy depending on the studies they can actually find and which suits them. And they think that we give injections willy-nilly and should be sent to radiologists, which would be about sort of 3 to 4 months wait. So poor patient is sort of waiting to have an injection for about nearly 4 months. Okay. Sometimes they never get to it. So it is difficult. So, there is no need to do a study because the pain would have progressed for another 4 months before they get injection.
Dinshaw, you give by the sonography or blind?
Sonography, but if I may say, I think, the debate for this doesn't really matter because if you're doing it by the anterior approach, you've seen a lot of guys are going intra-articular, many are going extra-articular, which is going to be, rotator interval region or the coracohumeral ligament. So, whether you do it ultrasound or not, you're going to get it either in the intra-articular or the extra-articular, and both seem to give you those results. So I don't think it really matters. At our center, we do all of them ultrasound guided.
Pratik, sir, you were saying something?
Yeah, I was saying the same thing because to save time, we do subacromial. But even if you're trying, because most studies have shown that if you use ultrasound, you'll be more accurate. You'll be getting 98% where you want. But even if you, as Disha was saying, even if you put extra articular, it does work. So in either ways, whether you are inter or extra, if you're putting from the front, you will get your result. So that's why we do it, by bony landmark guided injection.
So this was our another question which we asked that.
Can I ask what volume do you give mixed with local anesthetic? Obviously, you only got 1 ml of sort of steroid, but what volume of local anesthetic does everybody use?
Yes, important question.
Okay.
Indeed, because there is adding to that, to what Kush is saying, if you add 10 cc of lidocaine, that is a part of hydrodilatation what you are performing together with the effect of your injection. So
we are using 2 ml of
exactly
2 ml of the lidocaine. That's all.
Yeah, I use 10 cc.
Okay.
So I use 10, and if I can use more, I will use more.
Okay.
Makes sense. Yeah.
I use 0.25% bupivacaine. I make it 9 ml of bupivacaine and 1 ml of the steroid. So total volume 10. Do subacromial, so that also spreads in the subacromial space, and that also helps the cause.
Fantastic. Raghuveer sir, you were saying something, I think.
Yeah, when you're giving intra-articular also, I go in subacromial space and try to give in the rotator interval. Okay. Around 10 ml.
Okay. In the rotator interval. Okay.
It is only this, basically without blind.
To the next question. So the question was, do you give single shot or do you repeat after second if there is no response, or anyway, whatever, I'll give 2 or 3 injection at weekly or 15 days interval routinely, or with respecting some people don't give. So we said don't give at all. And this is what we felt that likely that majority use single. There are some people who repeat after 3 to 4 weeks if there was no response. So here I want to know how many of you repeat the injection. I never repeat. If I've given one, it is just not a repetition. Even, then I have to find out why is he not responding? What's the reason? Because in 90 to 90%, 5% people do respond to the single shot injection. So if he's not responding, it really bothers me rather than just injecting one more. So Ram, throw some light on this. Ram?
Yeah, see, no, I rarely give injection, but when I give only one injection, no more than once. Because if it is intra-articular or subacromial, it should work. If it does not work, it is not going to work. But I'm a bit surprised the Issaquah's indication is at least 3 injection over a 6 months period for indication for arthroscopic release.
I myself have seen some of the incredible surgeons abroad giving every week 1 injection. So I just wanted to see how, Ashish, what is your take?
You know that I hardly give any injections.
That's why that this is for you. The green column for you.
Green zone is me. Yes.
Okay.
Yeah, I'm also in the green zone, but when I give, only give 1 injection.
Only 1. Anybody, Yap? Do you repeat your injections? Yap, Sundar?
Well, sometimes I do, but sorry.
Sorry, I give only 1 injection. I want to ask one more question. So how many of you give injection even to find out a diabetic? If the patient is a diabetic, still you go ahead and give an injection? Steroid.
No,
Okay,
unless the diabetes is controlled, we never give injection. That should be the consensus. Diabetes has to be strictly controlled.
Very good question. I think we did not raise it here.
Vivek was asking maximum 2 injections, maximum with a gap of 4 weeks to 6 weeks. Maximum.
So let's ask this question in a different way.
Yeah.
One is a patient who is not a known diabetic. You diagnosed him frozen shoulder today, and you saw that the sugars are 200, 220. You did X-ray, whether it is diet control or whether it is the tablet control, medical control, and then you call them at X date, and you have a patient who is already diabetic. So in general, I believe that nobody would be giving an injection to a frankly diagnosed diabetic today, unless he goes and gets controlled and comes back. But even if he's a controlled diabetic, what is that cutoff sugar value today, RBS, which will say, no, you should not give? So can we have a value? What value do we follow?
There is no, excuse me, there's no contraindication to give an injection in a diabetic. You just warn them their blood sugar will be high for about a day or 2.
Okay.
Some of them might get a sort of what they call the sugar rush or the sort of flush, the steroid flush. And you warn them, they can take some paracetamol. I tell everybody who had an injection to take some painkillers that night, otherwise when the anesthetic wears off, the pain will be worse. So they get paracetamol, or they take their paracetamol if they wish to. And there's no contraindication. The studies are that if your blood sugar is, or your diabetic level is controlled, you will have a 1 day of rise blood sugar. If it's uncontrolled, you'll have 1.5 to 2 days. It's not persistently. They will not be sort of adversely affected by giving them a steroid. Mostly are sort of checking their blood sugars themselves. The ones who do not know, you warn them. You warn everybody that they might get a sort of sugar rush, and just be careful. And they don't complain.
So I can tell you, when I did the literature review, yes, I mean, I can't really comment because there's nothing in the literature when he's first time diagnosed diabetic, what should you do? But there is a recommendation in literature that if the today's sugar value is more than 250, you should avoid. Less than 250 you can do. I was following 200, but when I did the literature review, I got this 250. And very rightly, Dr. Kush said that after giving injection, there is a theoretical risk of infection, how it doesn't happen, but most of the time there is a flare in the the levels, which can vary from 24 hours to 10 days. But most of the time it comes back to normal. We are only scared about if there is a sugars are 400, and if it gets infected, you are in a soup, patient, maybe we will feel bad, or patient may come back with the. So what is the opinion of House Ashish? Anyway, if you are giving, would you like the sugars to be, can you give an injection in a patient who's got 350 sugar?
No.
Unlikely. That's too high. You have to make a judgment call here. I don't think there's any particular value. If somebody is in great pain and the sugars are lurking at 200, 250, I would still go ahead and warn and counsel that it will come down to normal eventually, not a problem. But as far as possible, if it's above 50, it's best not to.
Anybody wants to make a comment on this particular issue?
Vivek, I asked this question particularly because we tend to see these uncontrolled diabetic patients very often, because I know my cutoff is also around 200 or maximum 250. Because many times you see the uncontrolled diabetics always on the day of injection. If you want to give an injection, always I check for sugar level. So that's why I asked this question.
Just give me a second. I can tell you the whose reference is this and who came out this with 250. Actually, there is a cutoff value of 250, which since it was not a part of this, so I just avoided a bit. Physiotherapy.
I think the ISACOS recommendation is also not to consider steroid injection if significant diabetic. Is that right?
Well, no, the statement they made in the consensus that it is not a contraindication.
Okay.
Gives
So
articular.
There is a study by Waterbrook et al. In 2017. I can tell you this is Waterbrook is Waterbrook. This was published in it's a blood glucose levels after local musculoskeletal steroid injections in patient with diabetes mellitus. It's a clinical review in Sports Health, and so published in Sports Health. It's quite a big journal, published in 2017. So maybe all of you can have a look. So they recommended that 250 is they did extensive literature and they said 250 is a cutoff. Beyond that, it should be avoided.
But you were talking about the muscular injection, intramuscular?
No, they spoke about the intraarticular injection.
Okay.
Okay. So next we go on to the okay. What is yes. So do you think, my question to you is, before we move on to the next one, do you think a single or a multiple steroid injection, because the last one said multiple injections can be given, even the ISACOS says that, okay. Do you think a single or multiple steroid injection can cause full thickness tear, especially if there was a pre-existing partial tear in case of a frozen shoulder?
I think percentage of involvement is important. How much is the partial tear?
I agree, Nilesh, but unfortunately, I'll show you the literature. It's a bit confusing, so I don't have a very clear answer.
Well, to be honest, I'm more worried about the cartilage than about the tendon in the frozen shoulder.
Again,
that's the reason I think repeat injections are contraindicated.
Correct. So 60% of you think that it will not cause repeated. Again, I think the question comes, where are you injecting? How far you are away from the tendon, but I don't know. But I'm going to show you the literature review. So this is this comes from, okay, I'm sorry. Yeah, this is Ramirez et al. In 2013. So they did a prospective trial with 53 patients and they gave a single subacromial shot of 40 milligram triamcinolone. And when they did the trial, their 45% patient already had a pre-existing partial tear. They have not mentioned the tear size. They have not mentioned any location. 6 weeks later, when they repeated the ultrasound, they found that 17% had developed the full thickness rotator cuff tear. And 66% happened in patients who had a pre-existing tear and 30% de novo. So it means there is a 60% chance that if there's a partial thickness tear, it may happen, that it may get converted. And Nilesh, very rightly you said it depends upon what is the size of tear, what is the location. But unfortunately, that study does not quote that what was the, where was exactly the tear and what was its size. Another study which came from England with 230 patients with subacromial impingement. Here they gave 128, less than 3 injection and 102 more than 3 injections steroid subacromial injection. And this is the table where they found about 50% patient in less than and 47% in more than 3 injection got tears of variable size. You can go, and statistically there was no difference. Oh, I'm sorry, I have not put it here. Okay. So here again the question was that they have not written in their study, even though they did MRI, they did not disclose what was the status of cuff before injections. But seems to be that if there is a cuff tear of any size, there is always a risk. So maybe we should be very cautious giving injections if there is a cuff tear. And that's where I come back to my first point, that often if I want to intervene, I usually use ultrasound to say that there was no cuff tear before I inject. And my sonologist informs me, he says that there is a 30% tear, 40%. You want to go ahead and give me injection or should I wait? So it depends upon my judgment and I'll say, okay, go ahead on stop. So what is the house's opinion on this? Would you give an injection to a patient who has got a pre-existing cuff tear of any size?
I would, yes.
Never.
You will go ahead.
It should be never.
Let's face
And Vivek, and we have not done any investigations for these cases when you do injection. No, we don't go for an ultrasound. And we have not done any ultrasound and MRI before we give an injection. Many of the cases, if you diagnose as a primary frozen shoulder, and we tend to, if you don't respond, we go for injection. Maybe it's a good idea because nowadays, when we also, I don't give a blindly. Now I send to musculoskeletal radiologist because my radiologist is so interested and she wanted to give all the injection. So I'm referring to her.
You can actually tell them the same thing. You can ask them, they just have a cursory look at the cuff.
Yes.
They can inform you. And then
correct. Yeah.
Judgment whether you want to give or not.
Yeah, that is advantage now because if we do an ultrasound guided injection, I think maybe it's a good point.
That is why I come back to my primary thing that in general, I have had out. I usually want to do an ultrasound to see what's going on. You know, because subjecting every patient to MRI is a bit tricky.
Yeah, because we're in this case also because we're intervening. I'm giving an injection. So it is good to do an ultrasound so that we can diagnose whether you have a cuff tear or not. That is good. That is a good thing. If you're intervening, definitely ultrasound is useful.
So do we agree with this that reports about there are reports about development of full thickness cuff tear after subacromial injections? Repetitive injection, I personally felt that we should start avoiding unless there is a very compelling reason, could be 1 in 100. And careful in the cases with partial cuff tear, which are more than 50% in secondary frozen shoulder. However, more studies are required, prospective control trial, to prove this last particular thing. Anyone who wants to contribute? Dinshaw, Raghuveer, anything? Swanendu sir? Yeah.
Yeah, well, I have a little bit questions about the quality of these two studies. The first study you showed, we all know that ultrasound is not very sensitive and specific on partial cuff tears. The second study, there was no information on the pre-injection status of the cuff. So you don't know if it really, so I would not follow, or I would not believe the results of these two studies to base my activity or
I also agree with you, Yap. That's why the last line I have put more studies are needed to prove this.
Yes.
These are just two studies. If you actually go in depth of these studies, you find that they're not really, very well designed. There are a lot of flaws, especially the second study, which came with 230 patients. They have not mentioned even a word about what was the status of cuff before they gave it. They have done MRI and there's no description. I downloaded the whole paper, no description. So maybe because we all have been giving injection now for more than a decade and none came back with, especially those who did not had a tear, with a full thickness tear.
Yeah.
So I don't know. Ashish, you have some experiences in this, I think.
No, I don't have it. I hardly give injections, but we have noted that there are some of these surgeons who are old timers tend to give a lot of injections. If you ask them retrospectively, 20-30% of the patients will tell you that they've had many injections in the shoulder. I think it's just like a tender actually, and I wouldn't dare to give an injection in a cuff tear. But if that patient is about 80 years old and a cuff tear and in pain, I would be giving an injection for pain relief for those patients.
So let's go to the other contentious topic, that is the hydrodilatation. And we asked the people in our Indian practice that whether they prefer to use hydrodilatation. And almost close to 76-75% people said they don't practice hydrodilatation, very few. I got a call from Dr. Nishish Shah, and he said that he has been practicing, though he sent me the videos, which also showed that after the hydrodilatation, he manipulates. I've written him back that we really don't know whether the hydrodilatation is working or your manipulation is working. So that remains a bit of a conflicting issue. So
does he give steroid injection after he done hydrodilatation?
No, he is like a cocktail. So he gives injection, he dilates, then he manipulates, and then he gives injection. So I wrote him back, I said, sir, we don't know whether this is working or that is working. So if it's a pure hydrodilatation, then we can think that yes, it's worth. Anybody has got an experience on this hydrodilatation? No. Amit, Dr. Amit?
Yeah, I personally don't do them. We send occasionally to the radiologist, but my personal view is that, all of us have scoped these shoulders. Your capsule is often a centimeter thick. And I can't quite believe squirting a few ml of fluid in the joint is actually going to work.
Exactly.
So I personally would never consider hydrodilatation.
So this is why the literature, there is not much support coming for the hydrodilatation. I don't know, anyway, a lot of people are not doing, but outcomes has not been superior to a simple injection, intraarticular injection. And this is one study which we published in the skeletal radiology in 2020, and there's another study which has come up in 2018. The outcomes are not really superior to just an injection. Any comments here on the panel? So the question is, should we be recommending, or it's like a personal choice?
Vivek.
Yes, sir.
Vivek.
Yes, sir.
I have experience of a hydrodilatation, but the experience is absolutely number 0%.
I like your sense of humor. Anybody? So nobody.
We now have a problem because our commissioners do not want to send any patient directly to the hospital.
Okay.
So they all go to musculoskeletal physiotherapist, and then the musculoskeletal physiotherapist, if they choose to treat them, they will treat them. They have a setup with their radiologist outside the main hospital, and then they will only send the patients who actually require surgery.
Okay.
So they've recently been convinced by one of musculoskeletal radiologists who had made a contract with them, or the CCG commissioners made a contract. So every patient with a frozen shoulder goes to have a hydrodilatation. And the problem is that half of those diagnoses are not correct. So they send lots and lots of patients over, and they go for hydrodilatation. So we might have a jaundiced view from the point that we only get to see patients who didn't get better, because we never get to know which ones got better. They do not provide us any data. We ask them for data. Look, if anybody's getting better, we need to know what percentage are not coming to hospital. Absolutely. But what they do is they discharge them after about 3 months, one hydrodilatation. And if the patient has a problem, he'll go back to the GP. Then he goes back into the cycle. So he does 2-3 cycles of going to the musculoskeletal system, back to GP, and eventually will come to us. So we don't get to see any frozen shoulders till about 9 months. But some of them would have had hydrodilatation, and they did get better for a period of time, but then the condition gets, it's progressing, so it just comes back.
So guys, our next question. I'm sure that all of you know this. This patient fails to respond to all sincere efforts, which includes the analgesics, physiotherapy, injections, plus minus hydrodilatation, whatever. Patient has not responded well to the treatment. It's going on for 6 to 9 months. What's your preference? And so we knew that this is what is going to come, that majority want to do the arthroscopic capsular release. Very few, I think yesteryears, maybe it was 50%, but now only 10 to 15% people want to do the manipulation. And there is a subset who says that I don't want to do anything. I will just counsel and then rehab and rehab and rehab, and they will be all right in a couple of months to years. So, and then we also asked that what is your unpublished, experience in these, whether the manipulation does better or your capsular release. So 72% people felt that capsular release is better. Now I'm sure that all of you, including Yap to Kush to me or Ashish, everybody has done. Ashish, I would not say anything. Almost everybody has done manipulations at some or other time. Now, do you find difference? You had difference with manipulation. And leave apart the complication. We will have another slide to come up for that. Do you think that there was a very significant difference between manipulation and capsular release? We'll start from Yap. Yap.
Well, it is difficult to compare because I have no scientific data how the range of motion was.
Correct.
But generally, the capsular release is more satisfying than the manipulation. If I remember the manipulations I did a long time ago, I had seen some complications, plexus problem, which I never have seen with the capsular release. And
okay. Nilesh?
It is a very natural way of treating.
No, you do rarely, but when you did, do you remember that it was terribly bad or it did not make a great difference? And what was that, if you have any data with you?
So unpublished data, if I were to say, I think capsular release, they don't tend to be as painful, and they rehab faster. In the long term, I feel I would go with the equivocal option here, that according to unpublished data, I don't think that there's much of a difference in long term coming back to normal.
Okay, Swanendu sir?
I tried few in the beginning of my practice, but afterwards I was so frightened, I left it.
Okay, Dinshaw.
Yeah.
Dinshaw.
Manipulation as the treatment on its own, I've never done. So no real experience with just manipulation as a treatment modality.
Including when you were in KM, you never tried this, never tried on hands. Okay, right. Ram?
No to manipulation as alone treatment. The advantage of arthroscopy is precise relief and early recovery of movement and long lasting.
This is what it says, that the reason probably why of late in last decade and a half, the ACR, arthroscopic capsular release, has become more so-called preference, because the entire release of contracted tissue and debridement of synovitis or inflammation is very under vision. And sometimes you have missed the pathology, whether the investigation has missed or you missed. It is possible tackling that pathology when you're doing arthroscopy. And the literature says that rotations are better restored, especially in the earlier phase. When it goes to later, if you evaluate this very same patient at 1.5 to 2 years, they are nearly same. But when you see the phase of 6 weeks to 3 months, the rotations are better restored in ACR. And if happens, God forbid, the MUA complications can be devastating. Probably that's where Swanendu was telling, or Dinshaw and everybody says that probably that's the reason. If you're compelled to do, the complication can be devastating. Even if it happens in one patient, it's the end. Sundar, you're saying something.
No, you didn't ask me this question. I was waiting for this question.
I thought.
Sorry, no,
Sundar, I was waiting for you to answer.
Yeah, see, Vivek, yeah, I think I agree that arthroscopic capsular release is a direct visualization. You have a controlled release. I definitely feel it's a much proven. And the manipulation under anesthesia also, we have experience of more than 20 years. And I'm doing a randomized study.
Okay.
Already I finished almost nearing 100 cases. Maybe another 1 year we are about to publish.
Fantastic.
And if we have a controlled manipulation under this, if the technique is okay, there is no major complications. And I'm doing an MRI documented study, which I didn't have any drastic complication which we expect in manipulation under anesthesia, like a fracture or some other issues, which so far we have not encountered even before the study, even after the study. Yes, I agree that rotations are a bit limited in the early stages and the first 3 months after manipulation under anesthesia when you're comparing the group of capsular release, but end of the 6 months and it is almost equal. So still in our hand, manipulation under anesthesia holds good and it gives equal result to the capsular release.
So same
that's the key difference, because what we see in our practice is manipulation done elsewhere with the problems like labral tear, cuff tear, dislocation, fracture. So who does the manipulation is also the important factor.
Absolutely.
So it is like ultrasound.
Unpublished. Let me finish, come back to you. In our unpublished experience on 50 consecutive patient many years back, we were actually documenting, unfortunately we did not publish then, documenting pre and post manipulation, especially what happens to cuff. I have no idea what goes wrong with the labrum. We did not find any labral issues. Okay. Having said that, then the world changed, the times changed. We started doing more and more arthroscopic release because of the legal issues. We didn't want to have any complication and tomorrow patient coming back. But as you very rightly said, Sundar, if you are in a perfect technique, you can avoid the complications. There is a study by Leonard Funk, if I correctly remember, published in Arthroscopic Belgica in 2013, where they also did not find any damage to any extra-articular structure. They could not find anything with the cuff and the labrum, but they also did not find any damage. So, but anyway, the next slides are quite interesting. So,
yeah.
Yes.
Even though you pull off a labrum or you take a piece of small sector of bone with the labrum and you manipulate because you're not able to sort of rupture the middle between the humeral ligament or the capsule, it doesn't really matter in frozen shoulder. It all heals up as you would expect it to. And personally, there hasn't been much of a problem. Problem is the timings. In the state system, it's very difficult to get anybody in hospital within a short time. So manipulation can be done within sort of 4 to 6 weeks, while surgical release will take them about 9 months to wait for their surgery. So it's been equal results for manipulation or surgical release. we compare the ones who got surgical release first, they still got frozen and they may require a further manipulation, and they still went ahead and had manipulation. But one thing I found was that if you've given them a steroid injection, it's much easier to manipulate them, even though they were still stiff. It's much easier. The capsule is a lot more supple when you manipulate them as compared to the ones who never had a steroid injection. I don't know what the sort of forum feels.
Okay, Amit sir, you wanted to say something. You have raised your hand.
Yes, Vivek. I just want to say, currently, I suppose most of us don't do manipulations and we have given it up for whatever reasons. But when I did do manipulations, I anecdotally remember there were two distinct types. There's one where you manipulate and you get this crack noise and suddenly you get all your movements back. And there is the other one when you try to manipulate, you just get this elastic stretch. Those are the ones I think which didn't do very well. So I think, this is just very anecdotal. I don't have any scientific basis to support what I'm saying, but I don't know, maybe this has been the experience of some of you as well.
In a question, we wanted to know what is the most preferred time for doing the manipulations or ACR, whichever. And I think most of you would agree that it has to be done when the, the capsule is kind of frozen, it's really tight, not in the beginning. So anybody wants to say anything to this? If it has to be done, it is somewhere between 6 to 9 months is the most optimal period.
Very important.
Okay, so because what is said is that if you release, I think one of you are trying to say, if you try to release it before 5 to 6 months, it can actually aggravate the inflammation. And some of the patients who have come to us who underwent ACR, so-called ACR, or even the manipulation, their symptoms were terrible. They actually went into kind of a local reflex sympathetic dystrophy. So I don't have any document, it's just an anecdotal evidence, but it could be counterproductive if it is done beforehand.
Yeah, I do highlighted that one. Do not operate on the freezing stage or the patient is having painful stage, because the inflammatory phase and the patient not following your postoperative protocol or whatever reason, then they go for terrible refractory stiffness. Who underwent arthroscopic capsular release is very difficult to manage.
True.
5 to 6 months minimum.
That's the one of the, since there are still some people who do manipulation, we wanted to know that in general, what happens? Have you encountered any complications or not? That was the survey. So people said close to 47 people. We modified our question in the way that did you do or did you encounter somebody else's complication? So overwhelming, almost 47%, almost half the people said yes, they did encounter some or other complication. We didn't want to ask whether it was yours or somebody else. And then when we went ahead and wanted to know what happened exactly, so the majority were actually after the no experience, it was fractures of the proximal humerus and rotator cuff tear. Labral tear, probably they could not figure out much because, for that, either you have to do arthroscopy or you have to do MRI and maybe, but so that's why the manipulation, I think in today's era can be very, very dangerous. And, even if there's a 1 or 2 complication, it's hard to explain to the patient that what went wrong, why did you do this?
But I don't agree for dangerous word. I think you should learn the proper technique and do it.
Right, Sundar, but the thing is, if we say this, then, everybody will say that it's fine in hands of Sundar, it could be in hands of mine.
Yeah, I understand.
These platforms have to be very clear, that has to be a very well-trained shoulder surgeon.
Yeah, I agree.
He has observed these techniques. He knows exactly to keep such a short lever arm with a very controlled way you can do. But if you just say that, yeah, it's safe, equally safe to do manipulation, then we can open a Pandora box.
Yeah.
We are talking about manipulation as a standalone treatment, because when a very stiff shoulder, sometimes we also gently manipulate forward flexion abduction to get the whole thing to do the work. So in our hands is different, but when it is translated to general practice, it's or general orthopedics.
That's very difficult. Yes.
I'll put one different question here. Have you seen the Laurent Lafosse technique of entering into the joint through the rotator interval when the joint is very stiff? Because sometimes it has happened to me, the joint is terribly stiff.
Yes.
And you don't want to actually, manipulate. You want to struggle. Have you tried this anterior entry?
Well, in only 1 or 2 cases where I failed to get in posteriorly. I still think if you use the standard posterior superior portal, there is a very small chance of damaging the cartilage. And but sometimes it was so stiff that, well, in another case, I even needed fluoroscopy to get into the joint. But you can try the rotate interval, but I think it is a little bit more risky than using the standard posterior superior portal.
So Pratik, you have any trick in your sleeve, Pratik and Dr. Raghuveer, that if the shoulder is very stiff, extremely stiff, and you are finding difficult to go in, what method do you deploy?
As PM said, I'll go with a smaller sheath, and slightly the portal will be superior.
Okay.
And instead of going with obturate, I just put a Visingerode and do it first.
Okay.
Instead of you can try all this, then most often you will enter this.
Okay, Pratik.
Yeah.
Otherwise, you can go with the.
On a couple of occasions, I've used image intensifier and Visingerode, as Raghuveer said, because it's thinner. And once I feel I'm in place, over that I railroad our scope and have been able to get in.
Anybody wants to share anything? Dinshaw, in a very tight, stiff shoulder, what's your trick? And you don't want to manipulate, because that's one another trick. Okay, you gently manipulate and then you break some capsule and you don't want to manipulate. So what's the trick?
So not in idiopathic frozen shoulders, but sometimes with these post-operative and post-traumatic stiff shoulders, we've had to do an extra-articular sort of approach. You know, you get into the extra-articular part, see the capsule from outside, and then start taking the capsule from outside and then get in, like we do for the elbow joint. So, but that's relatively rare. In most scenarios, from the posterior portal, in a frozen shoulder, at least you can get in. Once you've gotten in and you get that rotator interval out, then automatically it starts opening up.
Okay, so we almost move on to this. So when it comes to manipulation, what survey we did, I don't know the world over, but what survey we did, 47% did encounter some complications of MUA by self or others. Fracture, rotator cuff tear, and labral tears did they encounter. Likelihood of complication remains high. That could defy the purpose of MUA. And I'll add in the, the maybe Sundar's thing, that especially if you're not really trained in the entire shoulder, surgery. If you are just trying to embark upon manipulation, can be very dangerous. And avoiding the forcing a range of motion at the end, extremes of rotation and a short lever arm is the key to if you are performing a MUA. And that brings to our last question, which was, I think Dr. Kush or Amit were talking about, that do you think that the patient with diabetes or hypothyroid fare poorly and take longer time to recover as compared to diabetics, non-diabetics or euthyroid, and it is proven in literature beyond doubt? So our people also said yes. And there's enough literature to say that the course of recovery can be prolonged. So maybe that's one reason sometimes it is better to do, and you have a clarity that why this patient is not responding. And you can always say maybe, that, okay, you may take a little longer time as compared to the normal population. So I'll leave this question open to everybody and let me know what is the opinion of the house. This is actually this is the two publications which are done, one in JSCS, another one is the Orthopedic Journal. So according to the diabetics and hypothyroid patient, they always take longer time to recover, both surgical and conservative. And that should be the part of counseling. So even if you do the release in diabetic, they are a bit slow to recover.
Diabetes and thyroid
they don't do so well. The diabetics or all other systemic conditions, they don't do so well after the management of the frozen shoulder. But they will get there. It just takes a lot of time, and they keep on getting recurrent frozen shoulders. Even after one treatment, they'll come back with an even stiffer shoulder. And again, there's a lack of motivation in some of these patients. I don't know why. Maybe they are more iller, or they have other problems in their life. They just don't do so well, and they don't seem to be as motivated as some of the others.
Exactly.
I don't know what the panel feels.
The second part of his answer is motivation, because I see a stiff refractory course in the uncontrolled, poorly controlled diabetic. Maybe the key reason might be that they're not compliant very much with the diabetic treatment. Equally, they do with the frozen shoulder treatment. But a well-controlled diabetic, I don't see a big difference.
No, you're right. Now, can I put something else? We are not treating the frozen shoulder. We're treating the effects of the frozen shoulder. I think what we must all understand in managing a frozen shoulder, you're not managing the frozen shoulder, you're only managing the consequences of you getting a frozen shoulder. And I think that that message has to be put across, that nobody can change the course of frozen shoulder. Only thing which causes them pain is what restriction, and what we're doing is taking away the restriction and the inflammation. We're not treating the frozen shoulder. That will carry on irrespective what we do to them for its natural course. Some have a shorter one, some have a longer one. All we're doing is bringing the time they suffer with frozen shoulder to a shorter time, rather than actually changing the course of the frozen shoulder. I don't know if I put that succinctly, but you're not taking the inflammation away.
Yeah, I think that's correct. Exclude secondary causes of stiffness and make sure that the patient you're treating is a frozen shoulder. And you're trying to understand the stage of the frozen shoulder by the clinical presentation, not by the time factor. And then you try to modify to make the disease or the progress shorter and effectively returning the patient to their daily routine and function early as possible, with some sort of treatment with no big sequelae or complication risk attached to it.
Yeah, I agree.
You were saying something, Raghuveer sir?
Yeah, I think the time is coming down.
Yes.
What is not discussed, can I tell, Vivek?
Yeah. Go ahead.
Go ahead.
So I believe with Ram's statement, I want to reduce the duration of the course. So what I do is, if patient is having stiffness, I give steroid. I give steroid and to reduce the pain. I'll tell that we are giving steroid only to reduce the pain so that it will facilitate the exercises. I tell him to come every day, twice morning, evening for first 5 days. Along with steroid, I give a suprascapular nerve block myself. It is only to reduce the pain. The nerve block is not meant for paralysis. It is only for pain relief. So once the pain relief is done, within 1 or 2 days, you will get the movement. Once the movement, the excursion happens, the duration of the course will come down.
So how many of us actually practice the suprascapular nerve block?
I don't pain relief of frozen shoulder.
Okay. Yeah. Ram.
Yes.
In frozen shoulder, Yap, you practice this?
Yes. If my intra-articular injection is not effective, I never give a second one, and then I send them to the anesthetist to have a suprascapular nerve block.
Where they give and how much they give and what they give?
Well, they start just with local anesthesia.
Okay.
And see what happens. And if it is effective, they never give phenol, but they have corticosteroid.
Though it is recommended, though there is a discussion about it in the literature, but I somehow skipped it today. Ashish, what is your take on this?
We always give a suprascapular nerve block for our rotator cuff repair patients once the block has worn off. I've given it for a frozen shoulder because I believe the effect is transitory. It lasts for more than a few hours or a few minutes. So it's not going to impact the long-term effect.
Dinshaw, do you give?
Not suprascapular nerve blocks, but if a patient has RSD, a shoulder hand syndrome, which is a similar pathology, but a different real thing, then we'll get a stellate ganglion nerve block done for that, but not routinely for frozen shoulders.
Okay. Pratik, so you
never tried with the suprascapular nerve block for this frozen shoulder. Never tried.
Yours is the best answer. Pratik, sir, you were saying something.
Yeah, we never tried suprascapular, we don't give. But I was saying that there are 3 different groups. The people without diabetes, diabetes controlled and uncontrolled. Because diabetes controlled, they fare better than diabetes uncontrolled. And that's where your first question was there, where HbA1c was required for the same reason, for counseling, that how the patient is going to fare in long term and what you feel and what you're going to be ready for. That is why the HbA1c becomes important to clarify clearly that this person is diabetic and to counsel. So that is why the 3 of groups, they actually behave differently.
So I think now we have finished the entire discussion on whatever limited 2 hours time, whatever we wanted to discuss. I'm sure that there are many points left over, but we have covered most of the contentious topic. The We are almost 5 minutes over the final time.
Yes.
If anybody wants to make one or comment, we can, and then we close. I thank all of you for giving your extremely valuable opinion and
we have to thank also the SESI members who have taken valuable time to fill up the questionnaire. Over 142 SESI members. I think it's a great benefit for the members of the society to learn from this valuable discussion, Vivek. Thank you very much.
Thank you. Anybody?
Yes, thank you all the faculty.
Yeah.
Yes. Well, two things. First of all, I would like to compliment the board. And second, I would absolutely advise you to publish it because it's a very large survey, very worthwhile to publish.
We are already in this just started doing this. Yeah. So probably in few months time, you'll see this published.
Yes.
Perfect.
Anybody wants to?
So that it will be of very use to the Indian Shoulder Surgeon Society.
Yeah.
We should have. Vivek, we should have a consensus statement coming out afterwards.
No, I'm
circulated.
So we had last time also rotator cuff statement, and now we'll come up with this final statement, which will be verified by all of you. Then we'll float it on our society. Yeah,
Perfect. Okay. I think it's also time that we change the term frozen shoulder. Frozen shoulder. It's like the cervical spine guys talking of neck pain or a crooked back or bandy legs. These are terms which are not really medical terms. I think a frozen shoulder as a medical diagnosis becomes over time. I think we need to get a better diagnostic terminology for the condition itself. And I think calling it idiopathic stiff shoulder is probably one of the better options, at least right now, as against frozen shoulder, which is really a layman's term.
Or idiopathic or primary word should be joining to that.
Yeah. Maybe. Yeah.
Jab, I've got a question to Jab.
Yeah. You've got a question. Yeah. Go ahead.
Question is that suppose we have got the consensus, we have discussed the issue of frozen shoulder. What should we write on the very first shot on the prescription? Whether to write the stiff shoulder, frozen shoulder, adhesive capsulitis, and periarthritis is out of the way.
Yeah, well,
what do you write on your prescription? What do you write on your first prescription? How do you write?
I would write to write down. I would choose frozen shoulder because in the consensus of the ISACOS, we still speak of the frozen shoulder. I can understand the considerations of Dinshaw, but I think it's better to follow the general consensus, and it is frozen shoulder is for the idiopathic one. I think the term we still use internationally.
Okay. Sending the information to general practitioner. It's no point confusing the poor general practitioner with the wonderful names of a condition which he most probably knows as a frozen shoulder.
Yes.
Or you could perhaps call it as a primary frozen shoulder.
Yep, I agree.
Because otherwise, the frozen shoulder is the referral. I'm sending you a patient with a frozen shoulder. You would say you have been diagnosed with a frozen shoulder. So in UK, I started to practice that primary adhesive capsulitis only because of that reason suggested by Daniel Mock. So started calling primary adhesive capsulitis, secondary adhesive capsulitis. But then the adhesive capsulitis is off now. So I think you should be calling like a primary frozen shoulder and the secondary.
Yeah, so you've done better than the general practitioner's diagnosis. Yes.
Okay.
Thank you very much, guys. It was
Thank you very much. If there are no more comments, thank you, everyone. Thank you.
Yes, thank you.
I mean,
Thanks.
Bye-bye.
Bye.
Thank you, Vivek, for sorting it out so well.
Excellent. Thanks.
Very nice, Vivek.
Well done.
Thank you.
Thank you, Vivek. Thank you,
Thank
Ram. Take care.
Take
Bye,
care.
Vivek. Thank you.
Bye-bye.
Thanks.
Bye-bye.
Bye-bye.
Bye.
Bye-bye.
Bye. Take
Hey,
care.
Sundar.